Great. Great. Thanks to organizers and for inviting me to give this talk. So in kind of the WCVIS model of kind of clinical VIR and kind of comprehensive clinical care and lifelong longitudinal value of the patient as a focus, I'm going to talk about some tips and tricks to get there. So we talked about this a little bit yesterday, the history of VIR, and it's important to know where you were, what worked and what didn't work, anything you do, whether it be when it comes to, studying history is just critical so you don't repeat the errors of the past. So Sven Seldinger, 1953, made a radiologist in this field of invasive medicine or invasive angiography, where they actually punctured the human body to take pictures into arteries and livers and various organs. Needle, without cutting down, needle in, wire through the hollow needle, needle out, catheter through, picture the human body because you're using the blood vessel as your highway to image everything. Well, it dramatically changed in this when this gentleman, Charles Theodore Dotter, who's really the father of vascular and interventional medicine. If you look at vascular interventional cardio, endovascular surgery, neurointerventional surgery, all of this came from or even a lot of GI came from this construct of what Dotter developed. He was a visionary, developed stents, clot busting medications directly into the clot. He was one of the earliest chairs of the radiology department. In June of 1963, June 10th, he was invited by Joseph Roche to Czechoslovakia, and he gave a talk to the Radiologic Congress there. And he basically said this, which was kind of a mind-boggling, and like no one could, it's like, having a, going and meeting extraterrestrials kind of concept at the time, that the angiographic catheter can be more than a tool for passive means for diagnostic observation. Used with imagination, it can become an important surgical instrument. No one would have thought that. And a little over 6 months later, he met Laura Shaw, who was a lovely lady in her 80s, 82, with severe heart failure, who had gangrene. So she was at a very high risk of losing her leg. And in fact, everyone said, you need an amputation. You need a below knee amputation. You're too sick for a bypass. And she absolutely refused an amputation. So then Dotter was asked, is there anything you can do? And just like any interventionalist today, is like, we always figure out solutions for problems and when no one else can. And using a coil spring wire and these sequential Teflon dilators open up this stenosis. And you can see Laura Shaw looking at her films. And that's something we could do to this day, where patients are watching the surgery real time as we're doing it. Pretty wild. And at that time, Dotter was writing notes in the chart postoperatively, seeing the patient and postoperatively writing it. And it's shocking that many of us have not continued this trend. It's mind-boggling. So it goes beyond that. The field of collaboration between us and other endovascular specialists occurred back even in the 60s and 70s, when Mason Sones inadvertently figured out a way to do coronary angiography from a brachial approach. He cut down the artery and figured it out. Well, Melvin Judkins, one of the first fellows of Charles Theodore Dotter in the Oregon Health Science University, was asked by Albert Starr and Dotter to go to Cleveland Clinic to learn under Mason Sones. Well, Judkins, just like any interventional physician, is like, how can we do it better? He developed these catheters that are used to this day. If you go to any hospital, they'll have these catheters named after Judkins, called Judkins right, Judkins left. And they co-founded the equivalent of Society of Interventional Radiology for Interventional Cardiology called SCI. In fact, Melvin Judkins was the second president of that SCI organization. Pretty exciting stuff. Well, in the US, we did not adopt Charles Dotter's techniques or principles. There was a lot of brouhaha, and that happens in interventional and minimally invasive medicine. And when you want change, visionaries are never accepted. You'll see that time and time again. Comprehensive clinical care, lifelong longitudinal is a construct that needs to happen in interventional medicine, but you'll see a lot of naysayers and you go, oh, this is not the most important thing. But clearly from the patient standpoint, it is. Well, no different was Dotter, not embraced here, but he was embraced in Europe. And that's why we want to bring our European colleagues and our international colleagues to understand these constructs as well, because we feel so vehemently strong that this is the future and this is the only way. And I'll tell you what I've learned from my European colleagues along my path. But Eberhard Zettler, a German radiologist, embraced this concept and took it to Germany and started using it. And it was one of the busiest labs in the world. And then Andreas Grunzig, who's an angiologist, worked at the Zettler's lab and learned peripheral things. And he listened to Dotter with great intent and great excitement. And he changed medicine forever when he did the first percutaneous coronary intervention, or PCI, where he dilated a coronary artery in the 1970s. Developed these balloons in his kitchen called the Grunzig balloon. Well, Julio Palmas is a great vascular interventional radiologist, was at UC Davis and UT San Antonio, developed the Palmas balloon expandable stent, which is a transformational technology that enabled us to keep dissections open or steep restenosis open. Again, many family members of yours will have one of these. They go cardiac intervention, they have that stent in them. Well, medicine continued to change with people like this, the great Kurt Umplotz, who was in the University of Minnesota and did a lot of pediatric cardiology, and he developed structural heart disease treatments. He's a vascular interventional radiologist who designed the Amplatzer devices to include PFOs, atrial septal defects and ventricular septal defects. So he did interventional cardiac surgery, structural heart. This was him. He also developed the field of endourology, where we're now going in and putting sheets into the kidneys and removing stones and doing these fixes and pyeloplasties, all from an endoluminal approach. So all this stuff is coming. It was originated in our field. This is a great slide of a 1980 angioplasty course that Andreas Grunzig ran. And the greats like Charles Dotter, Melvin Judkins, Mason Sones, even Dave Williams, a lot of these luminaries in endovascular medicine. Here's Kurt Amplatz, a young Kurt Amplatz over here. These are all endoluminaries, Andreas Grunzig. You know, the people who founded our specialty are in this one room. And we're hoping some of you will be the future of our specialty are in this room as well. Juan Prodian worked with who's a vascular surgeon, worked with Julio Palmas, that interventional radiologist who I showed, the vascular IR, who developed the balloon expandable stent, and they jointly put this device in abroad. Okay. But a third-year medical student in a similar time or prior to that developed a patent for a similar construct of stent graft. So again, a pre-med or medical student may have the ingenuity and innovation to develop something that we're going to be using in the next 5 to 10 years. Again, tremendous amount of innovation. I'm not going to go into it, but we talked about this yesterday. Let's talk about some of the people that I've really looked up to in my career as like kind of luminaries, and Michael Dake's one of them. He went to Harvard for undergrad. He was in internal medicine. He went to a medicine residency and chief resident at Baylor College of Medicine. Then he went to UCSF to do pulmonary critical care, and ultimately did kind of radiology. He switched into radiology and did vascular interventional radiology all there. Well, he published some of the seminal work on thoracic aneurysm repair and thoracic dissection repair using endovascular approaches. So the father of TVAR. And I look to him as a mentor now, which is pretty awesome. I can share a case. In fact, I'm going to share a case with him of one of my patients I saw in clinic recently to see what his thoughts are. And so I know he's at University of Arizona, and Navjeet Dullet gets to work with him very closely. But I mean, this is some amazing, land-breaking, mind-boggling work that's really transformed medicine. But to me, the original clinical VIR, who's really been touting this horn, was Barry Katzen. And he put his pedal where metal is, where he developed a place in Alexandria, Virginia, the first clinical VIR, and it still exists to this day. The infrastructure is there. But he also founded the world-famous Miami Cardiac and Vascular Institute, one of the premier training programs in the world. He started doing aneurysm repair in 1994. Pretty exciting stuff. He was a visionary, and he developed the construct along with Andreas Grunzig of live cases, one of the early adapters of live cases. In fact, ICED had his 35th anniversary this year. Pretty exciting stuff. Again, this is now Katzen with Michael Dake, both in the same Miami Cardiac and Vascular Institute lab, innovating at a pretty impressive rate. Again, changing medicine forever. The way we see medicine is dramatically changed because of people like this. I'm lucky to have come to the West Coast solely for this reason. I wouldn't be in Los Angeles if it wasn't for Tom McNamara having a clinic, because I realized that is the key to success and ultimately the best outcomes. He was a true clinician. He did his own wound care. So I'm like, I got to learn how to be a good wound care doctor. He saw 30 patients in office a week. These were aspirational and inspirational goals for me. I want to see 30 to 50 patients a week. He admitted his own patients. We take great pride in admitting our own patients to our service and managing their diseases. And really, our visceral practice has existed because of him. Now, this is an important quote that Dotter said 4 years after his first transluminal angioplasty, because he realized this field has to change and recruiting have to be surgeons. If my fellow angiographers prove unwilling or unable to accept or secure for their patients the clinical responsibilities attendant on PTA or angioplasty, they will become high-priced plumbers, i.e. technicians, facing forfeiture of territorial rights based solely on imaging equipment others can obtain and skill still others can learn. Don't think that because you're imaging or you're an imager that you can do this stuff or you have the equipment. No, cardiologists do echocardiography, cath, and everything, and most radiologists don't feel comfortable looking at those pictures. So it's not that. You have to know the organ that you're operating on. So this is what I'm talking about, my European influence. Well, this is the great Andreas Adam. He gave this talk called Vini Vidi Vanished. And this was kind of an eye-opening thing. The number one thing he said, are SIR and IRs fishing from the wrong pond? I.e., are we fishing from an imaging pond or are we fishing from a surgical pond? And he thought, yeah, we're fishing from the wrong pond. So part of the reason for developing WCVIS is to identify surgical types who will provide the best care for patients and really move the field forward as it should be. So what determines who does what, right? Like a UAE, a genicular artery embolization, it's not my technique. I can teach anybody these procedures within a month, a year. I can't teach them the clinical side within a month, a year. That takes 5, 6, 7, 8 years to do, right? And it's also, do you have the clinical infrastructure? Do you have an office where you can guide and counsel patients? If you don't, you're going to not have a sustainable career. It is not a sustainable model. And if your focus is on these rare skeletal dysplasias and not on diabetes and hypertension, how to talk to a patient, how to follow a patient in the office, how to do an exam, and how to interoperate on the patient, well, you're going to fail the patient and the public. We're great at innovating, we generate ideas, but there is a migration. So you need to stop that cycle where yesterday it was to the primary care, to a surgeon, then to us, or to a specialist, then to us. Now it's patient to VIR or patient to the primary to VIR, and that's sustainable. The specialist referrals are never sustainable. All right, there's something you have to think about in your lifetime. If you want to do something, you have to own the disease, and that's where we're transforming to and changing to. So what we're focusing on when you're developing a VIRAG is not the radiology types, it's the surgical types, because you want to focus on med students who want a primary role in patient care. They're passionate about surgery and procedural medicine. You have to have a stamina because these emergencies, these 2 a.m. postpartum bleeds come in, and you have to feel ready to take care of it. If you have a complication from a lung biopsy or a kidney biopsy, and no one's going to be as vested in making sure that patient survives that problem as you are. So you have to be willing to make those sacrifices to keep people alive. So what does radiology give you? It gives you anatomy and pathology. But if you think those 3 years, you focus on anatomy and pathology and you're not losing clinical skills, sorry, but you're wrong. I've seen it time and time again. Too many graduates come in and they're very uncomfortable. They're less confident than a medical student sub-I, which is a sad state. So we have to change that. So you have to remember and learn physiology, pharmacology, microbiology. These are as important, if not more important, than the interventional techniques that we can offer patients because they can be life-saving and mind-altering. So what's challenging? Head-to-toe anatomy pathology is very hard to learn. Radiology gives you the most efficient way to learn it, and that's why it's important. But what residency diagnostic imagers lack is they don't know how to do a physical exam or take a thorough history or admit patients or manage ill patients. They don't know how to manage diabetes or hypertension, and they lose how to talk to patients. And you can't lose that if you want to be a clinician. So the integrated VIR residency has to embrace and enhance critical clinical component of VIR training. You have to have an outpatient clinic with longitudinal care. If you don't, question going there. You have to have an inpatient consultation service, which is not a pre-op consult, but you're actually going to see the patient. And even if it's not something you can do, the average guys, you can't drain it. It's not like no window. It's like, hey, this patient should be a ciproflagyl for this long, or let's do this and change the dietary modifications. You make these recommendations. You need necessarily follow them afterwards and see if they're getting better. An inpatient consult service and admit to your own service. With that, we can do some amazing stuff. This is, again, patients that I've had the luxury of taking care of, a guy with basilar thrombosis, Lockton syndrome that I did with my neurointerventionalist, one of my many fibroid patients who it's one of the most rewarding things to see that their quality of life is dramatically improved at 6 months or 6 weeks. Some of the thoracoabdominal aneurysm repairs that we get to do in these patients who don't have a lot of options, they're not that healthy. One of my Berger's patients, you saw a Berger patient yesterday that did an amazing DBA, and they're very challenging cases, but my first pedal loop years ago that I did with Consagra. But more importantly, as we follow her, she's become the biggest advocate of smoking cessation in the Berger group. That's more important. I mean, granted, very happy that she got the TMA and she survived without a BKA, but still, the fact that she's stopping smoking, that impact factor is powerful. And that she's able to told a lot of people to stop smoking is very powerful to me as a human. You know, we can do amazing things with thrombectomy. This is one of my patients in her 40s or 50s, the Takayasus, to have to meet her husband and son. And I don't know how long she's going to be on earth, but I'm trying to keep her alive and without hurting her, without causing strokes, because she has a single vessel feeding her brain. So these are the things that I'm thinking about. We have near infrared spectroscopy to prevent an ischemic event as we're occluding these vessels as we're doing this and preventing emboli to whatever brain she has. This is an exciting surgery on a patient of mine who was a Jehovah's Witness who ruptured an aneurysm. who he was awake. We were able to do it. Couldn't give him blood, obviously, and he survived. From 5 years out, he's I see him every year. His A1C is down to less than 7%. He's lean. He's really changed his life a bit, but he's looking great. And I get to see him every year, which is exciting. And to see where he was almost he was on death's door and he survived this is something that's more rewarding than the procedure itself. So let's talk about what you need to do. First years of medical school, you need to study pharmacology, microbiology, anatomy, pathology, and physiology, and own it cold. All right. Cardiology, heart, lung, liver, kidney, brain. You got to know those organ systems like the back of your hand. Cardiology, pulmonary, nephrology, GI, liver, and neurology. Step one, as everyone will tell you, if you talk to Jonas, consolidate your knowledge, even this past fail. Learn that stuff well. That's going to differentiate you from everyone else. The extended set is that basic science knowledge. Third year, do really well in surgery. See if you can handle the VIR lifestyle. If it's not for you, maybe VIR is not for you. Learn anatomy and surgical techniques. Get medicine down. Get your physical exam, your history. And again, heart, lung, liver, kidney, brain. Own those diseases, including cancer. Obstetrics and gynecology. You can see we have a lot of overlap in women's health. So fibroids, TOAs, cancers, stroke and neuroexam. Get those things down in your neurology rotation. And get ready for step 2 and study hard for that. That clinical integration of knowledge is so important. All right. Fourth year has to be, it's a 7-year program. It's not a 6-year program. Fourth year has to be a real year. It's unlike your clinical counterparts who have clinic throughout, have all this, you're going to miss that. So you need to make fourth year count, meaning when you go to VR sub-I, if you're just a backstander or doing back table and operating all day, but you're not going to do clinic, you're not doing formal consults, you're hurting yourself. Go to a place where you're going to do clinic, you're going to see consults, you're going to own the disease, and then the catheter time. The catheter time is the easy part. You can talk to my med students, how much operative time they get and how, it's not the hard part. They struggle in clinic and consults comparatively. ICU, make sure you do an intensive care your fourth year. Do not skimp on that. Vascular surgery, cardiology consults, stroke neurology, and a surgical sub-I. Get ready for a surgical internship. As Shantanu is a big proponent of that, and it was paid dividends to him and others that we've trained now. Clinic, consults, post-op care and complications, ICU, operative time, endovascular surgery, and wound care management. Current integrated IR residency actually a step back from the clinical pathways that were developed by UVA and others. Unfortunately, this is what we were handed. We have to change it. 1 month ICU PGY5, you're a glorified imager, not a clinician. They don't know what to do with you because you don't have the fundamental skills that you need. So you have to change that paradigm by integrating ICU throughout training. Too little, too late. 3 months of VR in 3 years is grossly inadequate. This is something Eric Seiferson has been working on, where we looked at the different programs and how much clinic. You can see the various programs, and we can kind of give you some of this information that they're asked. But you should ask, how much clinic can I get to participate in, right? And it should not be a pre-op or post-op clinic. It should be a consultative clinic where you're not operating and everyone's sent to you, and you're following patients whether you operate them or not in a longitudinal fashion, often for the life of the patient. So what we're seeing is an attrition. This is a clear thing. And I think a lot of it is because a lot of these people are being sold surgery light, and they go, oh man, this is busy. And so they fall back on DR, or the surgery types are not getting enough clinical care the first 3 years. So we recognize this, and there is a true attrition, and we're trying to address this. Now, we can't be ostriches putting our hand in the sand saying it's not an issue. It is an issue, and we are going to address and fix it. But we need surgical types to continue to enter this field, and we're going to change this field forever. Current model of integrated 3 months of VR in 3 years, 1 month ICU is too little too late. You lose your skills. I see it time and time again. And it's become more and more challenging for us to train diagnostic radiology kind of people because they don't have that background that our residents are currently getting. They're just fundamentally different. I feel so comfortable with them managing my patients. I feel comfortable with surgeons managing my patients, but I also feel comfortable with kind of the integrated model. It's just fundamentally different. PGY2, we borrowed this model from UVA, 10 MICU shifts, VR monthly call, which I think is important, and 2 months of VR. So back-to-back months of VR training in your training is so important. 3 to 4 year, month of CCU, 4 months of VR, if you include the PGY3 and 4. So it's like a 5-month block where you're getting very good. And then the end of the 4, you're just studying for boards for diagnostic to pass the core. 5 year, more ICU and CCU and vascular surgery and neurointerventional, a lot of clinical medicine. And then 6 is mostly VIR and the latter half of 5. But you'll get very, very good by the end of that. And then we really focus on clinic. We basically have clinic throughout, half a day of continuity clinic. And the other thing is you need to get patients to your own clinic. We're not going to hand it to you. It's not like radiology where it's just like poof, trapdoor things are handed to you. You have to go and get referrals. So Zaim has done a great job. Austin's reaching out. He's gotten a few aneurysms to our clinic, and that's what you need to do. You need to learn how to get referrals as a resident or as a medical student to your practice. And so that's what the VIR clinic enables you to do. Get it with your name on it. Hey, this is referred to Dr. Billa, this Dr. Shinagawa's patient. That's what you want to see. And Kansagar, one of my colleagues, got a lot of that as a resident, and he continues to thrive practice building. So that practice building, if it doesn't happen as residency, it is not going to happen when you're an attending, or it's much harder. Learn how to do that now. So we've been able to establish a 600-bed hospital, 9 peripheral VIR, 3 extenders. I do 1.5 average to 2 days of clinic a week. We admit quite a few patients to our service. You learn a lot from admissions. One of our current patients who's got a symptomatic aneurysm with endoleak, she's got an AKI. So we're getting a FENA this morning. We'll see what her labs are and we'll see what is going on with her. You have a formal consult service, not a pre-op clinic, not a post-op clinic. And it's a true consultation for a disease, the true longitudinal follow-up. And you got to build all the service lines. You can't just be, hepatobiliary and trauma, and that's handed to you by the surgeons and transplant surgeons who have already made a decision. You're just kind of rubber stamping it. No, you want to own the disease, and a lot of times you're just going to follow patients. But you need to be the gatekeeper of disease, and you need to be the one making the clinical decision what should be done, not someone else. That's when you own the disease. But build all of them. And then we're expanding now. We have adrenal glands and thyroid disease and endocrine. So it's exciting because we're going everywhere in the human body. So it is becoming a surgical type field with a surgical lifestyle. It's a very busy being within the scope and complexity of practice. Remember, bleeders or clotters and septic patients are not going to happen between these hours of 8 to 5. They're not banker's hours. At some point, the old model pure procedure is going to be harder to justify. It's going to be seen as patient abandonment and quite frankly, unethical to do to our fellow humans. VIR will continue to transform medicine rapidly when we do it the right way. And I really think one of you in this audience, and this is why we're doing this conference, is going to be the next Daughter or Michael Dake or Barry T. Katzen or Kurt Amplatz or Julio Palmas. So why VIR? If you're thinking about it, it's patient care, it's longitudinal care. It's not limited to a single organ. You get to work with your hands. Remember this, and you're going to see this as time goes on, especially if you have family who've suffered illness. Patients fight hard, so we must train and fight harder. Thank you.